So I'd like to introduce our speaker for today, Dr. Shanna Barton. Dr. Barton received her medical degree from the University of Louisville in 2014, and then she completed a Med-Peds residency at the University of Louisville, ending in 2018. She then did a fellowship in pediatric infectious diseases at Norton Children's Hospital, and in 2021, she joined our staff as an assistant professor at the University of Louisville, affiliated with Norton Children's. Dr. Barton, special interest is immunizations and is the physician lead for the Norton Children's Vaccine Clinic. Her academic interests include understanding and addressing vaccine hesitancy, and her research centers on developing effective approaches in communication with vaccine hesitant parents and patients. Related to this, she developed a curriculum to train residents in effective communication around vaccine hesitancy. So it seems appropriate that she's going to be talking to us today about addressing vaccine hesitancy. So turn it over to you, Dr. Barton.
Wonderful. All right. Thank you for the introduction. I'm going to go ahead and share my screen. All right, so I'll go ahead and dive right in. I just do want to go ahead and disclose that I am a co-investigator on a grant-funded research project that does specifically focus on my work regarding vaccine hesitancy communication, and I'm going to share that with you today. And after completion of this activity, my hope is that you will be able to demonstrate understanding of factors and thought patterns that our parents and patients use to contribute to vaccine hesitancy, that hopefully at the end of this, you'll be able to describe general principles of effective communication to use with vaccine hesitant patients and their parents, and to also hopefully understand and perhaps even utilize a structured communication strategy in your clinical practice. And I think the topic of vaccination and talking about that with parents can sometimes bring along a mix of emotions, and maybe that depends on your background or your degree of comfort, or maybe just your clinical experience. And for some, it's exciting. This is an opportunity for you to do something in that moment to protect a child against disease. And this has been my facial expression since Nirsevimab has been approved, but I know that that is not how everybody feels. And sometimes when you're faced with the thought of parental concerns and hesitancy, maybe refusal, maybe you've met this family before and it's been a hard discussion and you do not have the time needed to really build a fruitful conversation and do everything else you need to do in such a short time span. Some people look a lot like this, and I don't think you're wrong in that feeling, and you're certainly not alone. So data from a national AAP periodic survey conducted in both 2006 and 2013 demonstrated that pediatricians do perceive and have perceived an increase in the number of parental vaccine refusals, going from about 75% in 2006 to 87% in 2013. And nearly all of the physicians surveyed reported encountering parents who refused and delayed vaccines in their practice. Now, those surveyed pediatricians reported that the most common reason that parents were believed to refuse vaccination was primarily because they felt vaccines were unnecessary, closely followed by concerns regarding safety and potential side effects from vaccination. Now, that survey is a little bit dated, as evidenced by the high prevalence of concerns regarding thimerosal and autism, and we know that that was from the now refuted Wakefield paper in Lancet. But when you look at more recent data, and I will also say it was maybe a bit biased because it was pediatricians who were surveyed, not parents themselves. So when you look at some more contemporary data, this is from a recent national estimate of hesitancy, looking specifically at parents in the US. They indicated that the item most commonly associated with hesitancy regarding routine childhood immunizations was concern about serious vaccine side effects. However, we know that the factors driving hesitancy are variable, and they may include a multiple of different factors. In the same study that I just referenced, it was noticed that hesitancy for flu, so thinking a little bit outside the routine schedule because it's something that's offered annually, the efficacy varies, the conversation is a bit different about that vaccine. When you look at it separate from the routine childhood immunizations, it was noted that the hesitancy for flu was 4 times greater than that for routine childhood vaccination. And while concerns about serious vaccine side effects persisted for both routine and flu vaccine, It was noted that other concerns became more prominent as well, and that perhaps these concerns led to concerns about other things. So, for instance, one of the most prominent factors was in regards to vaccine effectiveness, which led into concerns such as relative importance of the flu vaccine and necessity of both that as well as other immunizations that are recommended. Other studies have also demonstrated that additional factors associated with increased vaccine hesitancy include lower respondent education level, household income less than 400% of the federal poverty level, poor child health. In general, you've probably heard this, parents don't want to vaccinate a child who does not feel well. And then the child's age, specifically having a child who is entering preschool and needs some vaccines for school. Now, these attitudes and variables ultimately culminate into his decision to vaccinate or not to vaccinate. And while the majority of people do follow the recommended vaccination schedule, and most children are up to date, there are 23% of children who follow an alternative schedule, either limiting the vaccines the child receives at a visit or spacing them out over time, which does not follow the CDC recommendations. Or they follow some unknown, unclassifiable schedule, and that comprises about 15% of the population. Unfortunately, those children who are not up to date with vaccine recommendations are more likely to follow either an alternative or an unknown schedule. And as a result of the years culminating in vaccine hesitancy, in 2019, the WHO did declare that vaccine hesitancy was one of the top 10 threats to global public health. And COVID didn't help us at all, because the last 3 years and introduction of the pandemic have only propagated a problem by contributing to missed opportunities for vaccinations and introducing misperceptions surrounding both the COVID vaccine as well as other routine immunizations. And as a result, the WHO declared that as of July 2022, we are now experiencing the largest sustained decline in childhood vaccinations in approximately 30 years. Now, practically speaking, this translates to an estimated 25 million children less than 1 year of age who did not receive basic immunizations. This is the highest number since 2009, and an increase in the number of completely unvaccinated children increased by 5 million. And that just really blows my mind. Now, encouragingly, if there is an encouragement or a silver lining, while Americans' views on the benefits of some childhood vaccines have remained steady throughout the pandemic, most people are saying they're still beneficial. This is the right thing to do. There are signs that the COVID-19 pandemic has influenced the public perspective on one very important aspect of childhood immunizations, and that is in regards to requirements for children to attend public school. Currently, 70% of Americans say that only 70% say that healthy children should be required to be vaccinated in order to attend public school, which is a decline from the prior 82% surveyed in 2016 and 2019 who supported similar vaccine requirements for children. A greater percentage now say that it should be up to the discretion of the parent as to whether or not they should choose to vaccinate their child in advance of attending school. And some of this, I believe, and this is what this quoted as well, that this is a remnant of the politicization of the COVID-19 pandemic, with some groups very strongly resisting any activity restrictions or vaccine requirements that may impact individual choice, as well as a heightened fear regarding vaccine safety. And we know that this issue has extended even close to home, when as recent as March 2023, a measles outbreak occurred in Ohio, and a confirmed case in Louisville was also reported. And in response, Jefferson County Public Schools offered a vaccination clinic for parents, staff, and of course, children attending the school as a chance to receive needed vaccines, including measles, and they also offered COVID and flu. And alongside news of this clinic, which was a great outreach program, this statement just kind of made me double over. It said, we have nearly 12,000 students in JCPS who are not current on their measles vaccine, and they use that as a marker of other recommended routine childhood immunizations. So thinking about how many children have missed an opportunity and how we have let down by not getting them their vaccines. And how did we get here? We went from this great amount of data supporting efficacy and safety of vaccines, but we have shifted from polio pioneers, children standing in line, taking pictures of their vaccines, to protesters who are attempting to boycott our attempts to keep children and their families safe from disease. And so before we delve into how we should communicate with vaccine hesitant families, I'm going to first explore with you, how do we get on this path? How do our families and patients take the data that they're given and develop a posture of vaccine hesitancy? So I'm going to pose it back to you as the audience. What factors do you feel may contribute to vaccine hesitancy? And I think Dr. McDonald may help me with this chat. Absolutely. Misinformation.
Misinformation. Okay, yeah.
Yeah, I can see it too. So sorry, I wasn't
Okay,
sure
great.
if I could.
I didn't know you could see it.
I didn't know either. So absolutely misinformation. And I think that has absolutely propagated how our families feel about COVID. And it's really leaked into how they feel about other routine immunizations. Oh my gosh, social media. We will absolutely talk about that. Certainly side effects. We've seen that was even years ago. It's still a very high concern. Institution, fear of the unknown. These are all excellent. Okay, so we're going to touch on all of those things. So I'm going to divide this into external factors and internal factors. And the first of these external factors is cultural cognition, or the tendency to form beliefs that reflect and reinforce shared societal values. So people tend to perceive risk in alignment with underlying cultural orientation, and they interpret evidence in ways that strengthen their ties to an in-group. Even judgments as to what constitutes expert opinion and evidence-based data is subject to the dynamics of cultural cognition. What do you believe? Okay, well, I'm going to believe that too, because I think we align in terms of how we view the world, and where we're pretty close. We have similar viewpoints. Yeah, I'm going to go with what you think. That's cultural cognition. So take, for instance, the way in which HPV vaccine was initially introduced as a vaccine targeted against a sexually transmitted disease approved only for females. So as you can imagine, and as you may have experienced in practice, this STI slant to vaccination very quickly caused cultural divide, with parents claiming that HPV vaccine promoted sexual promiscuity, and it resulted in this very skewed risk perception where only females were viewed as at risk. And can you think of how long it has taken us to really backtrack from that initial rollout? So cultural cognition. And now, of course, of perhaps the most influential factors, social media. I think someone's hit the nail on the head there. What we have found is that there are spikes in vaccine hesitancy, which tend to coincide with new information, new policies, or newly reported vaccine risks. And we know hesitancy is not a new issue, but social media has resulted in an escalation in scope and scale, where you can find any sort of information, but you have to sift through a multitude of misinformation. There's a little bit of some accurate, scientifically based nuggets in there, but knowing where to look can be really difficult. And I think we've seen this play out very easily with the COVID vaccine. It's far easier to post and share captivating stories, rare side effects, negative videos are noted to have been viewed by a factor of almost 3 times as much as videos that promote positive perspectives of MMR vaccine. I imagine it is similar for COVID. Again, it's far easy to watch something captivating and scary than it is to watch disease be absent. We also know that social media allows people with shared beliefs to organize across geographic regions, whereas previously they may not have easily been able to do so. And this ultimately does disrupt public confidence and cooperation in our vaccine programs. But I don't mean to be discouraging. We know that social media is a challenge, but perhaps we flip it a little bit. And we use this as an opportunity to identify where our patients and parents are getting their information, but also use this as a way to guide them to appropriate evidence-based resources. Now, the last external factor I'm going to touch on is timing. And sometimes timing is everything when it comes to shaping vaccine hesitancy or acceptance. So while as many observers will point to the 1998 Lansfield article by Wakefield et al. As the source of parental fears that MMR might cause autism, the search for what might be contributing was already brewing. And in the US, there were anxieties already focused on thimerosal and vaccines as a possible cause of autism. And this attention heightened when simply a precautionary measure by the FDA called for an assessment of thimerosal in childhood vaccines. Now, there was no evidence of harm, and it was strictly precautionary. But when the US Public Health Service and the AAP provided a recommendation to remove thimerosal from vaccines, what do you think it did? reinforced public concern. They said, well, why would you remove it unless it was an issue? It was strictly precautionary, but that's not how the public views it. And so why do I matter? Sometimes these things are completely out of our control. I say that because if we attempt to address what we believe the influential factor is, MMR vaccine versus maybe actually thimerosal, if we miss the context in which these concerns arise, we may inevitably completely miss the target as to what is driving our parents and patients' concerns. So how do our parents and patients utilize all of these external factors around them and influence their interpretation of facts and misinformation? And this is kind of where we come into our internal factors. And the first of these I like to touch on is confirmation bias. And that's a tendency to seek out evidence supporting what we already believe, ignoring contradictory evidence, and failing to formulate beliefs based on true data analysis. So what I mean by that is that many parents will start with the belief that vaccines are harmful. They'll ignore anything else to the contrary. They'll seek validation for that belief, and they'll even find providers who support and share in those beliefs. And second is the idea of faulty risk perception, or the perceived value of vaccines paradoxically decreases as their effectiveness increases. So when vaccines work, disease is not prevalent. People don't see it, so they don't perceive a benefit. And when you combine with this with widespread attention given to, again, very rare adverse effects, the result is a skewed risk perception that maybe vaccines do more harm than good, and maybe it's better to just get immunity from natural disease. And now there is also a tendency to perceive meaningful patterns where maybe they don't exist. And we look for patternicity as a way of deciphering through this background noise. And this is a pretty extreme example. But take, for instance, the grilled cheese sandwich in 2004 that sold for over $28,000 because someone thought it looked like the Virgin Mary. This is not how my grilled cheese sandwiches looks, and I'm very devastated. But just follow with me here. Imagine that somebody sees a pattern that every time they get the flu vaccine, they get sick. Okay, well, they decide, okay, well, I'm not going to get vaccinated anymore because every time I get vaccine, I get sick. That's the problem. And so it's really important for us to step in and help our patients understand the difference between associations and perceived patterns as opposed to true causation. Now, whereas scientists do tend to think probabilistically, we calculate odds before we come to conclusion, most of us, myself included, we do tend to think heuristically, or we come up with shortcuts or rules of thumb as our way of thinking in order to simplify our complex decision making. So for instance, parents are often more tolerant of a bad outcome when it results from their own inaction rather than action, or the do no harm heuristic or omission bias. The intuition that it's morally worse to harm someone by doing something, vaccination, as opposed to not doing something. So for instance, some people are more tolerant of severe complications from flu disease that occurs naturally, as opposed to side effects from vaccination. And unfortunately, simply appearing to somebody's altruism or good heuristics has very little impact on encouraging them to vaccinate. I can't just say, please do this for the good of the community. Most people say, no, thank you. But it is very important for us to share with our families that it is equally important that there is just as much consequence with not vaccinating or an absence of action as there is with an action. By not vaccinating, they ultimately leave their child susceptible to disease, which is equally a concern. Now, in addition to patient factors, we know that healthcare providers are equally influential in comprising the vaccine hesitant population. In a recent national survey designed to assess physician confidence in vaccines, it was reassuring to note similar feelings among primary care providers and the general population regarding the benefits and efficacy of vaccine. Everybody said, for the majority, vaccines are important. But when you look over here on the right side of the chart, as you get some trickle down numbers, the same study also demonstrated some discrepancy, that 10% of physicians do not agree vaccines are safe, 9% don't believe they're effective, and 8% pictured here do not agree that vaccines are important. Now, you may say, well, those are some small numbers. They're not the majority. That's okay. But when you realize the primary care provider is frequently cited as the primary source of information, and we'll talk a little bit further, they're very strongly an influential factor in parental decision-making. This small proportion carries a very heavy weight on the patient population. And so while it's equally important for us to understand interventions on the patient side, why they're hesitant, it's equally important for our interventions to focus and create efforts to build confidence among our providers. There also may be some citation of insufficient knowledge, inadequate time. I mean, I get longer visits than most, but I know there is a lot to do in your well care visits. And when you reach someone who is hesitant, it feels like you just don't have enough time to address all of the concerns. And then other physicians may say that perhaps the decision to vaccinate is just beyond their control, that parental attitudes, their concerns, their issues, their level of hesitancy is just too great for them to overcome, and they're unamenable to change. So now that we've explored some factors that contribute to hesitancy, I'd like to introduce a working definition of vaccine hesitancy. Now, although the tendency may be to view vaccine hesitant persons in the same light as those who are strictly anti-vaccine, recognize that attitudes regarding vaccine hesitancy do fall along a spectrum. And vaccine hesitancy does comprise a variety of actions, including acceptance, deferral, and refusal. Appreciate that most people, upwards of 75% you encounter, are willing to accept and receive your recommendations to vaccinate without hesitation. Recognize too that on the far left there, while the anti-vaccination movement does exert a significant influence, they constitute only a very small percentage. There is a very significant difference in the staunchly anti-vax and the well-intentioned hesitant. And it's important to make this distinction because you have opportunity for change with someone who is hesitant, questioning, and has a right to think about their healthcare versus someone who is very staunchly adamant that they will refuse vaccination. Now, the definition of vaccine hesitancy has not always been very clear. Very early definitions were broad, they were vague, they were trying to encompass this just wide array of emotions and contributory factors. You can imagine that wasn't very successful. And then on the opposite end was vaccine hesitancy being strictly referenced as the action. Did you vaccinate? Did you not? Were you ambivalent? How did you respond? But I think vaccine hesitancy, and many in the literature will say vaccine hesitancy is really far more complex than either of these definitions. And so I really prefer this definition here, that vaccine hesitancy is a state of mind regarding immunization characterized by uncertainty, indecision, conflict, or opposition, and it's best understood as a multifaceted, complex problem. It has both deep sociocultural and psychological roots. And we know that this kind of makes sense, right? All those factors we talked about come together for decision making. And this is really that period of hesitancy. It's a period of vulnerability, a period of opportunity. And we have to also recognize that just because people may feel this way, these beliefs may not always predict a decision to delay or refuse vaccination. So I think this does get a little bit more at really what the heart of vaccine hesitancy is. It's shifting more into this ground of the feelings, the intuitions, as opposed to did you vaccinate or not? And so how do we start to tackle this problem? Well, when I broach the conversation of vaccine hesitancy in my office, I like to just tell families off the bat, I'm not carrying a vaccine in my pocket. We're not going to do anything that they as a family feel uncomfortable with. We're just going to talk, which as an ID doctor, that's my only procedure is I talk. We talk about expectations, concerns. I'm going to share information as we go along. But when communication is the only tool in your tool belt, you got to be able to do it effectively. And so where do we even begin? And I'll turn it back over to you as a response question before I talk through some of my strategies. I'd like to know, are there any strategies that you think work well when communicating with vaccine hesitant families? Oh. Okay, well, this is great. Maybe I have stuff to talk about. Yeah, tell me what you're worried about. Open up the floor. I love it. My boss likes to call that word vomit. We just say, hey, you just tell us what you're worried about and we'll go off of that. Perfect. Motivational interviewing. That's absolutely something that we're going to talk about. Thank you. Exactly. You tell me what you're worried about. I'm not going to make any assumptions about why you're hesitant. Perfect. So I'm going to go through a few general principles of communication. And as I do so, I'm going to use HPV vaccine just to illustrate some of my points. I'm not saying it's HPV vaccine specific by no means. I'm just giving you kind of a foundation for how this might play out with one of the vaccines. So currently, there are several general principles that have been advocated for use in communicating with vaccine hesitant families, all with varying degrees of empirical support. First off is how a provider initiates the conversation is a very important determinant to parental resistance to vaccine recommendations. A presumptive approach assumes a willingness to vaccinate. Again, the majority of patients are ready to accept your recommendations. And it also initiates a conversation with a declarative statement that shots will be given at the visit. In contrast, a participatory approach often incorporates a shared decision-making model and may include open-ended questions. Well, what do you want to do about shots today? I always love it when parents look at their kids and say, hey, do you want the flu shot? Well, they don't. They're a teenager. Nobody wants a shot. So we do the presumptive approach. And how does this play out? In a cross-sectional observational study reviewing videotaped provider-parent vaccine conversations taking place during general routine well visits of children 1 to almost 2 years of age, the way in which a provider broached the conversation was studied. And in 84% of cases, providers initiated the conversation as opposed to a parent or another staff member. 74% of providers initiated using a presumptive format, that declarative statement, versus 26% who uses more the open-ended participatory approach. And now, interestingly, I didn't picture it here, but that participatory approach was used more commonly among a vaccine hesitant cohort. However, among all parents, a greater proportion of parents resisted vaccine recommendations when a participatory rather than a presumptive initiation format was used. And this finding also remained true among the strictly vaccine hesitant cohort as well. Now, for many, this approach may seem a little counterintuitive to that recommended collaborative shared decision-making model that we've been taught to engage in. And I'm not saying that's wrong. You should have a partnership with your patients. But when there's really only one medically acceptable choice, in this case, vaccination, then really a shared decision-making model is inappropriate, and I think it sets your families up to fail. Furthermore, that presumptive approach works because the majority of patients, again, are willing to accept vaccines, and so a presumptive approach doesn't invite conflict where there may not be any. And in practice, a presumptive approach may look like this. Now that your son is 9, he is due for vaccination to help protect him from HPV-related cancers. We're gonna do this today, that action statement. So I feel it just necessary to say this. Please hear me. I'm not saying to give up on the partnership. I'm not saying that you need to be strictly paternalistic and ignore your patients. But what I'm saying is that you need to have the authority and the professionalism in the room to say, in the same way that you recommend car seats, seat belts, gun safety, that you recommend vaccination. So what if your patient vocalizes resistance? They have issues, concerns following that presumptive statement, which many will. Well, then the providers are encouraged to remain firm, emphasize that their clinical experience, the available data makes them an authority in this matter. So in the same study in which parents resisted initial recommendations, 50% of providers pursued their initial plan and said things like, I really think this is the right thing to do, or your child really needs these shots. And despite initial resistance, 47% of parents ultimately accepted the recommendation after the provider pursued it. And this number did include 27% of vaccine hesitant parents. Again, not trying to be dismissive, just emphasizing your initial position. Now, while some families may be purely data-driven, we certainly cannot underestimate the influence of personal stories and anecdotes. Parents' concerns about vaccine safety occur within the context of the community in which they live. And so therefore sharing similar concerns that they can identify with, maybe describing your own experience, can sometimes be a strong driving force to help influence families' decisions to vaccinate. And perhaps the conversation looks something like this. And I think somebody even said it in the chat, would you like for me to share my experience? Or what is your experience? Maybe we can bond over that in regards to HPV vaccination. Did anyone else take a picture like this? I'm sure many did. I mean, I was up there in the top right corner. This is my entire ID division. And it wasn't strictly for social media purposes, though it did certainly overlap from that external factor we talked about earlier, but this was a way for us to normalize vaccination. Hey, I got my shot. I'm doing okay. I'd like for you to get your vaccine too. It was a way for us to reinforce the social norm of vaccination. I think it is very important that our patients and families understand that the vast majority of children will receive all recommended schedules, vaccines according to the schedule, like we saw in that pie chart earlier. So if we reinforce the social norm, we say, hey, this is what everyone else is doing. Maybe you should jump on the bandwagon too. Sometimes that can help. And for HPV vaccination, this could translate into a statement such as, now that your child is 11, he's due for vaccines to protect against tetanus, meningococcal, HPV-related cancers. We're going to put them all together. We're going to give those vaccines today. We're not going to isolate anything. We're not going to make it seem special. We're going to normalize everything and do it right on this vaccine visit. And we also need to remind our patients why vaccination is important, emphasizing the health risks, the benefits, but also saying, there is some risk. There are some local side effects. We can be honest about those in our conversation. And maybe it's a simple statement such as, this is the benefit of vaccine. The HPV is the only vaccine and most successful prevention tool against HPV-related cancers and genital warts. And I think that accomplishes that task of emphasizing the benefit. And then something simple, such as these are anticipated local side effects, can discuss the risk of vaccination. However, the way in which providers convey these messages has a very significant impact on families. For instance, in a study focusing on effective messages of vaccine promotion, parents were presented with one of 4 interventions commonly used to promote vaccination. And these included providing families information about the lack of evidence to support a causal relationship between MMR and autism as detailed by the CDC, presenting information about the dangers of disease prevented by vaccination from the vaccine information statement, displaying images of potential diseases and associated complications of children who are afflicted by disease, and using a dramatic narrative of a child who almost died of measles. And so they studied, okay, well, how should we talk to families? How do we deliver these risks and benefits? Unfortunately, none of these interventions were found to increase parental intent to vaccinate a future child. And furthermore, images of sick children, that very dramatic Macaulay Culkin narrative, actually increased parental beliefs of serious side effects of the vaccines, thus perpetuating misperceptions about vaccination. And this is referred to as the danger priming effect. So it is therefore very important to tailor communication to that individual family, because even well-intentioned pro-vaccine messages, as you can see here, don't always work. Parental concerns also tend to center on their interpretation of the scientific evidence regarding vaccine safety. Yet, as we saw, paradoxically, as research shows that correcting scientific misinformation doesn't always go as to plan and doesn't always change behavior. And if you don't execute it well, it could end up into something that our division likes to call fact tennis, where you just parry physician facts with the provider facts and you go back and forth with this very unproductive communication. And so the conversation for HPV may look something like this. Well, my child is too young for the HPV vaccine, says the parent. But I want your child to be protected before exposure, says the provider. But HPV vaccine promotes sexual activity. Well, vaccination does not actually change sexual behavior. But HPV vaccine is only important for girls, not for boys. But boys are equally at risk for HPV-associated cancers. And you can appreciate this back and forth, back and forth. And there's really no way to get out of this except to not enter into this conversation. So avoid fact tennis where you can. Now, in that previously described study, it was also demonstrated that while providing scientific information was the most effective at disproving the misperception surrounding MMR vaccine and autism, there was also a notable decrease in intent to vaccinate a future child among parents with the least favorable attitude toward vaccines. There was no significant impact of the other messaging systems among the other groups. And this is perhaps because respondents called to mind concerns of other vaccines to defend their attitudes, or maybe correction of one statement causes confusion and parents misremember it as truth. So this illustrates that the best response to false beliefs is not necessarily correcting misinformation. And so the bottom line here is that when you respond to questions and concerns, use facts sparingly and appropriately depending on the family. Avoid playing fact tennis. Be honest about known common side effects. Don't say there are no side effects. We know that's not true, but be upfront and honest about what parents can expect. Be careful to not answer unasked questions, which may ultimately trigger new concerns and may cause families to misremember myths. Now, perhaps the general principle with the most robust supportive evidence is the idea of developing a trusting relationship. In multiple studies, physicians are routinely cited as a key factor in parental decision-making and a trusted source of vaccine information. In addition, many vaccine-hesitant parents will cite reassurance and information provided by their child's pediatrician as the primary reason they changed their mind and ultimately accepted vaccination. In a survey of postpartum women regarding attitudes and knowledge about vaccination, the theme of trust in the medical profession was the central concept that underpinned all of the themes surrounding their decision-making. And part of this ability to establish trust in the physician was finding someone who was knowledgeable, motivated to seek information, passionate about the topic, welcomed discussion, and was patient with the patient. And still further, the argument has been made that perhaps the process of communication is more important than the content. Or in other words, how a provider talks to a parent about vaccination may be as important, if not more so, than what he or she actually says. Now, much of the evidence to support specific communication strategies is reliant on the content of conversation or specific concepts that I've been talking about. However, this data ignores the relative importance that families place on attitudes, beliefs, feelings. That definition of vaccine hesitancy isn't really being measured because we know that those feelings, emotions, equally contribute to the decision-making process. So a lot of our data does not necessarily highlight that. Now, one communication strategy, I think someone did mention this in the chat, that has been promoted as a means of shifting focus from content to process is motivational interviewing. Initially proposed in the 1980s in the context of addiction treatment, motivational interviewing is a very brief intervention tool that incorporates a patient-centered approach designed to promote the patient's own internal motivation for change. You evaluate the source and strength of their concerns. You redirect the conversation in a way that promotes behavioral change by exploring their own internal feelings. So you base the conversation based off how they feel and how they're ready to change rather than assuming anything on your own end. You avoid giving unwanted or unnecessary information because essentially you have vetted out how they feel, what are their internal motivations, and then you use that to redirect behavior. And these are the 4 pillars of motivational interview, and they include evocation, or the act of bringing or recalling a feeling or memory, compassion, acceptance, and partnership. The themes of motivational interviewing include demonstrating an understanding and appreciation of the patient's perspective, listening reflectively, establishing a supportive environment, avoiding confrontation. Behaviors that embody these themes include asking open-ended questions, summarizing key points of the conversation, using empathetic and non-judgmental language, and limiting fact-based responses. The primary goal of motivational interviewing is to establish a collaborative partnership between the patient and parent, regardless of the outcome. Now, what that means is that even though we want everyone to get vaccinated, even if a family says, no, thank you, not today, the goal is still an open door policy. I'm here to work with you to take care of your child. Now, in one of the first studies to assess motivational interviewing as a means of promoting infant and childhood immunization, there was an educational intervention based on motivational interviewing techniques, and they called it PromoVac, or the idea to promote vaccination. And it was delivered to postpartum mothers. In a study of over 1,000 women, the intent to vaccinate at 2 months of age increased significantly by 15%. And in follow-up studies, they followed these children for years. They found that over the subsequent 2 years of life, children whose mothers had received that intervention had a higher chance of complete vaccination status compared to those who did not receive the communication. This study was really the first of its kind to demonstrate that communication makes a difference, and that it can improve immunization rates in infancy and young childhood. And there have been recent studies trying to build on this data. They use varied educational strategies, maybe multitude of interventions, and the results are encouraging, but they're a little bit difficult to attribute to communication strategies alone. And subsequently attribute improvements in vaccine coverage to communication alone. It gets a little dicey. And we've gone through all this, and you're like, I do not have time for this. I'm a subspecialist. I get to be a little biased in this way. I get an hour with my patients, and sometimes I still don't get to everything that we need to talk to. So I can't imagine being in a primary care provider office and trying to think about all of the things you need to do and also address vaccine hesitancy. And so we know that time is a barrier. We talked about that previously. And as a result, there may be some providers that fall on office policies regarding patient dismissal if the family refuses to comply with routine immunizations. But recognize that families are going to find care, whether you agree to care with them or someone else. They will find somebody who shares in their decision. Many families, after being dismissed from a practice, still express a very clear desire to establish a trusting relationship, and they will look anywhere: physician, naturopath, homeopath, family member, whomever, to support their decision, ultimately reinforcing their fears and misperceptions, and will successfully discourage that family from vaccinating. And so I always tell providers, would you rather them receive good care from you, continuing a good collaborative partnership, or give them to somebody who you know will be successful at discouraging them? Better to keep the door open as much as you can. And so to this end, we don't have time, but we mean well. There's been a lot of good data and literature trying to focus on developing structured communication strategies to interacting with vaccine hesitant parents. And I've given you a few of them here. The general formula for a structured communication strategy does incorporate some of those themes of motivational interviewing, providing information, acknowledging your concerns, recommending immunization. And many are just these simple, cute little acronyms that are easy to remember. I personally like EASE and RULE. The problem is that some of these will come across as formulaic as you sit there and go, okay, RULE. The patient is like, this is not a real conversation. And so it really does counteract that ability to create a good relationship. And then others will go to the exact opposite. They won't actually end up making a recommendation. They'll just reflective listen, open-ended question. And again, that presumptive style at the beginning gets a little bit lost. And so you can appreciate there's still trying to find a good balance. And unfortunately, many of these strategies do not have good empirical tests that they've been subjected to with rigor. And a lot of it is pretty variable, and the results are disappointing. I'll say that in the least. In general, when using these strategies, vaccination rates do not improve, and physician self-efficacy or confidence following training gets some mixed results. And so I think the bottom line is we still don't have the right answer just yet. But we talked too that it's just as important for us to not only address the parent and the patient and their perspectives, but make sure the provider in the room is confident about vaccines. So previously, the HCGME, or the Accreditation Council for Graduate Medical Education, did not include communication with vaccine hesitant families as part of the required training. There is now a shift, and as of July 2023, the revisions have been put into place, and it now states that residents must learn to communicate with patients and parents to partner with them to assess their care goals. This must include effective communication strategies with those who hesitate to accept recommended treatment, including vaccines. So even more fuel to the fire that we have to know how to teach vaccine confidence. And so, like I said, there is not one perfect strategy out there. We are still learning about how to do this well. But at our institution, and at least related to my research, which I'd like to share a little bit with you about, we were interested in one structured communication strategy in particular, and it's called the AIMS Method for Healthy Conversations, or AIMS for short. The idea is that it does incorporate elements of motivational interviewing, but the communication in general focuses on more the process rather than the content. Again, that shift that we saw, and it includes 4 primary elements: AIMS, announce, inquire, mirror, secure. As part of our study environment, because we do work with young physicians in training, we did separate out respond, which is technically a component of secure, because we wanted to be able to look at a subject's ability to gain trust, irrespective of their ability to provide evidence-based answers. Again, looking at process, not just content. And the goal of AIMS really is to shift that focus, placing emphasis on thoughtful inquiry, using those elements of motivational interviewing, and really at the heart of everything, it's creating a trusting partnership between the parent and the provider. And so I'm going to briefly walk through these steps. So first is announce, or that presumptive declarative statement that assumes the need for vaccination and declares your intent to vaccinate at that visit. It assumes vaccine readiness. Again, you're not being paternalistic. You're just not inviting conflict where there may not be any. And you are just creating a professionally confident posture with a statement such as, it is time for the patient shots, or they will get vaccines today. And if there's any evidence of hesitation or concern, the next step should be to inquire. And so as you're inquiring, the primary goal here is to understand the concerns, or what it really drives the patient or caregiver's concern, evaluating the strength of the concern, gauging their level of hesitancy. Here's those motivational interviewing techniques, and really presenting yourself here as an active listener. You can use phrases such as, well, what concerns you most? I think somebody put these in the chat. Give me some more detail. Tell me what is bothering you. I find that using how or what questions can be really helpful to facilitate that conversation. And you're trying to understand as the patient understands. Again, not making any assumptions, but I want to know what bothers you, not in the way that I think about this vaccine, but how is it affecting you, so that then I know how to best address your concerns. And then the next step is to mirror. This is really that reflective listening component. You're going to show that you understood what they said and demonstrate your understanding. You're not going to just repeat back to them what they say, but you're going to rephrase it. Make sure, okay, if I understand this correctly, this is what you mean. Or maybe you ask for permission. May I verify my understanding by repeating concerns back to you? And sometimes we get it wrong. And the parents are like, were you listening at all? And you try again. And that's the inquire and mirror process, which sometimes you do have to cycle through a few times to really get to the bottom of the problem. I think about it as the parfait in Shrek. You have to really dig to the bottom to figure out what the concern is. They come in about side effects, and it's really about a family member who had a bad problem. And it's more about the community that they're living in. And you just have to dig. So I really tell our residents, move beyond the surface, really ask and understand and gauge that level of hesitancy. Use this to drive how you're going to respond to the concern. And here's that response. We kind of separated it out because this can be difficult for young learners when you don't know all the answers. But again, we're going to be very sparing in our facts and statistics. We're not going to parry back and forth with fact tennis. We're going to be honest about known side effects. We're going to acknowledge what we don't know. And when opportunity arises, we're going to direct our families to authoritative resources. And of course, try to avoid asking unasked questions, because we don't want to include or perpetuate myths or misperceptions. And last, we're going to say and reaffirm our position and secure that partnership. I want to help you take care of this child. We're going to work together. I still believe vaccination is the right thing. And regardless of whether they agree or disagree, you're going to maintain professional, respectful posture throughout this encounter. Again, being firm in your recommendation, creating an open door policy. Again, the goal here is that collaborative partnership, just like we saw in motivational interviewing, regardless of the outcome. And that's really it. That's pretty easy. And you're like, okay, look, I don't have time for this. I know, but you're probably doing a lot of this anyway. Again, it incorporates those themes of motivational interviewing. It's the desire to create a partnership. And again, you're emphasizing process, not just what I say, but your feelings, your emotions, your beliefs. I'm trying to get you at that level to make sure we have a fruitful conversation. And so I know our time is coming short, but I do want to show this brief video as to how this actually works. It's very short.
Hello, Mr. Jones. How are you today?
I'm feeling better now. Thanks.
Good. Your test results look great, and your infection is gone.
Oh, I'm glad to hear it. I've been worried about it.
I don't want you to go through this again. So I'm going to help reduce the chance of that happening again by giving you a flu vaccine while you're here today.
No, not for me.
Would you be comfortable sharing your reservations with me?
Okay. Honestly, I prefer fighting off the flu in natural ways.
Just to make sure I understand correctly, you're saying that you already do a lot to stay healthy.
That's right, like eating organic foods, taking lots of vitamin C, every day.
And in addition to these natural means,
Oh, I also wash my hands with soap and water all the time.
these are all great practices. And since you just had a very serious infection, I'm worried about you getting another one. I'm sure you're just as worried as I am. We both want to do what's best to keep you healthy. Can you help me understand your concerns about the vaccination?
Okay. I just didn't think it was necessary. I'm trying to lead a healthy, organic lifestyle,
I hear you and share your concerns. Did you know that because of your age and your heart condition, if you get the flu, you have a greater chance of having a heart attack?
I had no idea it could be that bad.
All of the things you are doing are great. And I would like to give you the flu vaccine as another way to help protect you from getting influenza. I don't want the flu to take your life. May I give you the flu shot before you leave today?
I guess it would be a good idea. I've struggled so much with this past infection. I don't want to go through that again.
I think that you're making the right decision for your health. This should be something that you do every year for the rest of your life to help protect you from getting the flu.
Thank you. I appreciate you taking the time to explain this to me.
Your arm may be a little sore after the vaccination, and you could be a little achy. I'm happy we're doing this today.
I agree with you there.
Call me if you're worried about anything. I am happy to discuss any other questions that you may have.
Thank you, doctor.
So if you take out the jazzy music, that took 2 minutes and 15 seconds. And we have been using this strategy as a way of helping to teach vaccine confidence in our residents. We include it as part of an annual curriculum that is conducted among the residents. They are taught basics of vaccines, and when we teach them aims, I'm not saying it's better than anything else, but I'm saying it's as good as everything else. It's short, it's effective, we think it works because it incorporates other general principles which have been shown to be effective. And then we actually throw them in with a standardized patient. We now, since COVID, have transitioned to everything virtually. It used to be in person, but it's like a telemedicine visit, and they get to actually practice with a standardized patient who pretends to be a vaccine hesitant parent. They hold their little infant up here. And this just ensures that no matter where you go out and practice and where you were for your clinic training, everybody gets the same experience in regards for training for vaccine hesitancy communication. And maybe you didn't train here, or maybe the thought of having these conversations is just awful for you. You're that irritable toddler at the beginning, and that's okay because I love them. And we have a vaccine clinic here at Norton, and I am happy to address any concerns about potential patients. We accept referrals, both for children who are vaccine hesitant, as well as special vaccine immunizations, immunocompromised persons, refugee or immigration status. Happy to help in all of those regards to make sure we get our children safe and healthy. And so I think the big take home points here is that just remember, and I think you know this, but vaccine hesitancy is complex, it's multifaceted. I don't think we're gonna fix it in that 2 minute and 15-second video. We may need a little bit more time, but just know that as you enter the conversation, it's okay to not have everything resolved at the end of a visit. Establishing a trusting relationship is key to creating a good partnership and to also encouraging that decision-making process. And that perhaps how we say something is more important than what we say. But overall, we do still need further research to establish efficacy of these structured communication strategies. So hard for me to advocate for just one, but maybe you can use some of the general principles we touched on in your practice. These are my resources. I hope these are helpful. I try to provide citations on each of my slides in regards to references, but these are some additional resources for those who may be interested. I'm happy to take any questions or comments in our last little bit here. And of course, send me an email if there's something you'd like to continue talking about.
All right, thank you, Dr. Barton. That was very interesting. We can see your passion for this subject, definitely. Enjoyed that. I was really surprised that 9% of it was it pediatricians or physicians feel like vaccines are ineffective.
That one kind of hurt my heart. I won't lie. You look at the graph and you're like, oh, we're doing good on that left side. And then you're like, you see the trickle down and you're like, oh no.
Yeah.
Yeah. It's I think it's pretty impactful when you put it in the context of you make the biggest difference as the pediatrician and you don't think vaccines are important. It just blows my mind. And we know that those providers exist. There's some in our community, but it just blows my mind.
That was surprising. All right. Let's see.
Yeah, I can see it.
There's some interesting, if you haven't, I know you were given the lecture, but you might not have been able to see all this in the chat, and it's interesting. You might enjoy looking through that.
Yeah, I'm gonna read back from where I stopped. So some pediatricians are choosing not to give vaccines in their office because of cost, choosing rather to send their patients to the health department. It is a decision to pay their staff rather than vaccinate. Oh my gosh, we have had just this, that's so funny. We had this conversation this morning in our division meeting because I said, my pediatrician has had a hard time getting flu and COVID. I'm taking him to the vaccine clinic. And they're like, can you do that? I was like, yeah, anybody can do that. We have shot only appointments. We'll get your kids their vaccines. But you're right. It's so hard when they're saying, well, we can't offer it, go to the health department, the strain it places on a family to, I mean, my gosh, getting my kid to the pediatrician is like moving a mountain. To also then take him somewhere else to get a vaccine. Absolutely not. I like the posting videos on TikTok. So my pediatrician is a very good at social media. I'm awful. But I do enjoy learning from her and how she communicates with parents and patients using that platform. So I think if you're good at it, I'm not, but if you're good at it, yes, I advocate for social media just to show people and parents and patients kind of what you're thinking. I've always had better luck when I say that both my kids as well got the vaccination. They feel better. Usually, I'm assuming that's in regards to HPV. Yeah, sharing your experience. Yep, I love it. Yep, that percent of doctors are the loudest. Isn't that always how it goes?
Yep.
So
right. That's good. Let's see. Is there one question? Make sure. I've recently heard that many pet owners are starting to refuse rabies vaccines, citing concerns about canine autism. Is there a way to better cancel the myths that have continued to pass on since Dr. Wakefield published the article in the Lancet?
y'all, I'm not a veterinarian, but that's a challenge. I'd have to really dig.
Canine autism, huh? All right.
Hey.
All right. Thank you, Dr. Barton. Thanks everyone for joining us today.